Everyone. I am absolutely delighted to be here. Thank you for joining our session. It's my pleasure to be presenting with Fran today on palliative essential in long-term care foundations and care planning. Also, I would like to share, as Dela mentioned earlier, that ECHO will be offering additional sessions in the series. One is on June 4th, titled Conversation Aligning Care with What Matters. The second session is on June 18, called Person-Centered Symptom Management Addressing Pain. We really hope that you will be able to join us for these upcoming sessions. For today's sessions, we have three main objectives, as you can see on the slide. Number one is to understand the foundation of palliative care in long-term care setting. Number two is to recognize care planning opportunities to support residents' present and future needs. Number three is to identify and access resources to support continued learning and practice development in palliative care. Next
Gita,
slide, please.
just before we go on with your presentation, I forgot something. We were going to just launch a poll. Now that we have almost 70 participants, we just wanted to get a sense of who's with us today. And so, Esther, can you please launch the poll? And we're just ask you to give us an idea of who, of your discipline and background, so that we understand who's with us. So Esther, can you just let me know when there you go. Yeah, so just let us know what your discipline is. And we'll just take a couple of minutes to gather that up. And that will give us a better sense of knowing who's joining us today. And we're thrilled to see the variety of people that are here. Nurses, social worker, we've got some care assistants, we have some physicians, and we have some administrators. We've also note in the chat that we've got people others that we didn't list: recreational therapy, spiritual care, educator, nurse practitioner. So I'll just get you to we've got almost most people have answered. So we've got physiotherapist, speech pathologist. Maybe you can end the poll, or can I end the poll? There. And then share the results, just so people can see in the room, in our virtual room here, who we have. And thank you for taking the time to do that, and for also noticing that there's multiple professions. Somebody has got with music therapy as well that we haven't mentioned, their resident cat. So thank you very much. We're thrilled to have you all. And with that, I'll turn it back to you, Gita.
Thank you. This is great. Hey, we have different program and different professional. It's wonderful to be with you today. Thank you so much, everyone. So I'm going to talk about evolution of palliative care. As you can see on this slide, palliative care originally began as comfort-focused support for people who were dying, most often delivered. The care was delivered at home within within communities, and the care was kind of informal, community-based, not highly medicalized, with the primary goal of comfort and end of life. During 1960s and 1970s, the modern hospice movement emerged, led by Cecily Sandler. During that period, the formalization of the palliative care principle with a focus on holistic and compassionate care, addressing not only physical symptom but also emotional, social, spiritual needs. If all those holistic was kind of combined with the palliative care during that time. From 1980s to 1990s, palliative care expanded into hospital setting. At this time, it became closely associated with end-of-life care and was often introduced late in the course of the illness. In 2000 and 2010, growing research demonstrated the benefit of early palliative care delivered alongside disease-directed treatments. And today, palliative care is understood not only as a specialty service, but also as an approach to care. The core principles such as symptom management, communication, psychosocial support, alignment with residents' goals of care, care planning, they are all expected to be applied by all clinicians across all care settings, including long-term care. In summary, this slide shows how palliative care has evolved from community-based comfort care at the end of life to an evidence-based, person-centered care approach that should be integrated early and practiced by all healthcare providers. Next slide, please. So the next slide, this slide uses the bow tie model to show the importance of introducing palliative care early in a person's illness journey. As you can see, the blue triangle represents disease management, which may include treatments such as chemotherapy, radiation, surgery, and etc. This care is often focused on slowing the disease progression or achieving a cure where possible. The purple triangle represents palliative care, which includes pain and symptom management, psychosocial, emotional support, communication, support, and all the support is aligned with person's goals of care and values. As the illness progresses, the person moves from a continuum of care where disease-directed treatment and palliative care are provided together rather than as separate and sequential approaches. The key way is, from that slide, the key way is palliative care is not about stopping treatment. It's about adding another layer of support early, ensuring that care remains aligned with what matters most to the person throughout their illness. Next slide, please. So let's talk about evolution of the palliative care in long-term care. Traditionally, as we all know, palliative care in long-term care was often associated only with the final days or weeks of the resident's life. It was something we added on when a resident was dying. But today, our understanding has shifted significantly. We now recognize that most people entering long-term care have life-limiting conditions such as dementia, frailty, or progressive chronic illnesses. Because of this, palliative approach should begin from the day residents move in, not just at the end of the life. A palliative approach in long-term care focuses on family-centered in a way that is unique to the individuals. It means getting to know the person, getting to know their wishes, values, goals of care, supporting their families as part of the care team. This approach is integrated into everyday practice, how we are managing this residents' symptoms, communicating with them, care planning, responding to their changes over the time, and of course, at the end of life. The goal is to support quality of life through the entire illness journey, not just at the very end. So I think this is the time that I'm going to invite you to complete the poll. If we can go to the next slide, please. Yes, this is the invitation to participate to this poll and kind of reflect and answering this question for us. When does a palliative approach begin where you work? Thank you, Estelle. If you don't mind to answer this question, moving in.
Yeah, sometimes our systems are set up well for things to happen, and sometimes our systems lag. So it's interesting to just reflect what's really happening in your own care homes. Yeah, we'll give about another 5 seconds for people just to just take a stab when you think about, not necessarily your own practice, but the practice in your care home, and what do you see? What's happening within your teams? And, we'll just give another few seconds here, and we'll just get a sense of the people that have answered. What are people seeing with this? So I think we've got about 70%. Why don't we just stop the poll there, Esther? And then Gita will be able to speak to
Thank you.
that.
Yeah, thank you so much. This is very interesting. And it's great because during moving in, we are getting 55% of our participants are doing palliative approach to care, which is excellent. I am assuming we are doing the goals of care review, advanced care planning, updating most as needed. But only 7% responded in the last day of life. We are doing palliative care, which is very interesting. Palliative care starts from moving in until end of journey.
Yeah. And people could select one answer. So this was when did it start? And so, we've got a majority of people that start on moving in. And
Exactly.
some other care settings, there's other things that prompt it. So thanks for answering that. And I'll turn it back to you, Gita.
Thank you so much. Okay, I think we can go to the next slide. Palliative approach in long-term care. So overall, at the national level, palliative care framework identifies 12 core competencies area. It's very important for us to understand all these competencies apply in long-term care. However, for us in long-term care, the core competency have been refined into set of essential elements that are practical, achievable, and embedded into day-to-day care. These are the three essential care elements in long-term care on this slide. The goal of this essential element is to make palliative approach care everyone's responsibility, not something that happens only when a resident is actively dying or specialists are involved. Uh, This refinement is kind of supporting the care team to focus on what matters most in long-term care, such as ongoing symptom management, communication with resident families, getting to know the person over the time, planning ahead of time, and responding to the changes. If I can go to the next slide, please. Next slide talks about goals of care and advanced care planning. In long-term practice, goals of care conversation are not only one-time event, they are ongoing discussion that evolves as residents' condition, needs, and priorities change over the time. Effective goals of care conversation should begin during moving into long-term care. This is an important opportunity to understand what matters most to residents, their values, their goals of care, their understanding of their health, and who should be involved in decision making. This conversation also happening during care conferences where the interdisciplinary team and family revisit goals, clarify expectation, ensure care remains aligned with residents' wishes. Equally important goals of care discussion should be revisited when there are signs of decline or increased care needs, for example, changes in function, increases of symptom, repeated hospital transfer, or progression of the illness. Can I go to the next slide, please? Key element number 2 is about optimizing comfort and symptom management. In long-term care practice, this means screening, assessing symptoms regularly, such as pain, shortness of breath, anxiety, PTSD, fatigue, nausea. Assessment tools and documentation can help us ensure as changes are identified early, it is communicated clearly across the care team, and the outcome of the assessment, along with the person's goals of care, will inform care planning, pharmacological and non-pharmacological symptom management, and care planning. For example, a resident who highly values interacting with their loved one during visitor hours may have a goal of care that includes specifically being pain-free during visitor hours. This means the care plan will ensure that the care team will provide pharmacological and non-pharmacological management during visiting hours for that certain resident. Symptom management is not limited to physical symptoms. A palliative approach also ensures access to psychosocial, emotional support, spiritual care, and bereavement support for families and care partners. Next slide, please. Essential element number 3 is about being attentive to indicator of health decline. They may include unintentional weight loss, decreased function, reduced response to treatment, or frequent falls and hospitalization. Recognizing these changes early allows the team to pause, reassess, ensure care remains aligned with residents' goals of care. When changes happen, communication is critical. Information should be shared promptly with the residents whenever possible, with families and substitute decision makers, and also with interdisciplinary team. Care plans are then reviewed, updated to reflect residents' current needs, priorities, and goals of care. Can I go to next slide, please? So let's talk about why a palliative care is so important, is so needed in long-term care. This slide helps explaining that question. Most residents, as we all know, most residents entering long-term care are living with frailty, dementia, progressive chronic illnesses. Research shows that average length of time from move-in to death in long-term care is around 16 months. So while each resident's journey is unique for us, this reminds us that most residents are living with chronic and life-limiting illnesses that often get worse over the time. Their condition often get worse over the time. A palliative approach helps us anticipate change, align care with residents' value, adopt care plan over the time rather than reacting only when a crisis happens. This sets the foundation for earlier conversation, better symptom management, and more person-centered care throughout the resident's time in long-term care, not just at the end of life. And next slide is going to be Paul again, I guess. I would love to invite you to answer this question at your workplace. How often are conversation and care plan initiated to help resident and family prepare for decline?
I see that as people are answering that question, Maureen, in the chat, we're saying, even though we know that dementia is a terminal illness, it's often for a surprise for people coming into care or supporting those entering care. So you may know that change is anticipated and that people have illnesses they'll die from, but not necessarily the person or the family have understood that. So we'll just give about another few seconds here for people to chime in the poll. How often are we really, even though we know that change is to come, how often are we initiating to help residents and families prepare for decline? There's lots of different decline, and we're gonna dig into this more in the next bit. The next half of the session is we're going to dig into these elements that Gita, thank you, you've outlined for us. So we'll just give you another couple of seconds to answer the poll, and then for the remainder of the echo, we're going to dig into the care planning part, and the next two echoes will then go into goals of care conversations and symptom management. So let's just end the poll there, Esther. And you can see in the sharing the result that some places it's kind of like a third and a third and a third, where some places it's pretty integrated part of care, and other places it's frequent, and then sometimes it's potentially infrequent. So let's invite you, Fran, to carry us on, and thanks, Gita, for starting us off, and let's explore the care planning essential element in more depth. So go to the next slide, Esther.
Thanks, Stella, and yeah, thank you so much for having me here today. It's been such a joy working with the collaborative, and I'm happy to see so many people here today. So yeah, we're curious related to that poll to hear a bit more from you. So for those who selected always or often, if you'd like to add a comment in the chat, what helps those conversations happen where you work? And if you selected sometimes or rarely, what are some barriers to proactive care planning in your setting? I can share a story while people are responding from my experience in long-term care with one resident. She came in with an advanced disease, and when she got here and was provided with very stable care, her condition actually improved in terms of her function and mobility over the following months. Our palliative care team was involved to support her with her neuropathic pain related to her metastatic cancer. And so we had been kind of following along through her time here. And then at some point she did become unwell and she was admitted to the hospital. And during that hospitalization, there were just kind of a catalyst of events, and she ended up declining and dying in hospital. And when we were reflecting on the situation, we realized we really never had conversations with her about what she would have wanted if she declined. And we actually took her stability for granted, not recognizing that her overall health actually did remain quite fragile. And so, yeah, we ultimately didn't know if dying in hospital would have been what she actually wanted.
Yeah, Fran, just as you move to explore this, I just wanted from the chat, and these maybe we'll address them as a thread through the conversation, but just to keep in mind families and whether they are open to these discussions, just the issues of staffing issues, and then comfort, preparation for people actually to with these types of conversations, and the notion of feeling like people need to have developed rapport and relationships, that is one of the things that really facilitates the conversation, so deepening relationships. In some places also a barrier is potentially that the primary physician's wanting to seeing that as medical conversations rather than all team participating.
Yeah, thank you. These are really insightful responses in the chat. So thanks everyone for participating. We can go to the next slide. So we're going to focus for the rest of the talk on really digging into care planning, as Della mentioned. And so when we're talking about a palliative approach in care planning, we're thinking about what matters to the resident and family now, and also planning for anticipated changes. As Gita mentioned, we know that the average length of time that people are often in long-term care is around 16 months, which is actually a very short period of time. So when we're thinking about, we can go to the next slide, please. Thank you. So when we're thinking about what matters now, when we're developing care plans, it's important to reflect, are they grounded in what the resident wants, their needs and priorities, or in what the care team believes is best? So we can look to the Platinum Rule for guidance. It's not how we think someone should be treated or even how we would want to be treated ourselves. The Platinum Rule is how the resident wants to be treated. In long-term care, safety is a foundational part of how we support residents and guide care decisions. And at the same time, what is considered safest does not always align with what the resident would choose for themselves. So an example that I have is a male resident who was admitted to long-term care with a coccyx wound, and he was put on a Q2 hourly turning schedule to help offload and heal the wound. When I met him and asked how he was doing, he said, "Terrible. I'm being woken up every 2 hours. Someone came in and grabbed my foot at 4 a.m. How would you feel if someone did that to you?" And so we had a discussion. We talked about the benefits to his wound healing from being turned, the risks of, prolonging the healing of the wound or it not properly healing if he isn't offloading as much. And he was very clear that his goal was to sleep through the night, and that's what he wanted. And that's what was going to help him have good quality time during the day, and being woken up, did not align with what he wanted. And so we liaised with the team. We mitigated the risk by getting him a pressure relieving mattress. And then his wound actually did go on to heal. And so we were able to honor his values there. So a palliative approach to care planning really starts with understanding what matters most to the resident, not necessarily what we think the best treatment plan is for someone. Next slide, please. So in terms of recognizing decline, this might be familiar to some of you on the call, but an important part of a palliative approach to care planning is, anticipating this decline and looking at illness trajectories can help us understand the patterns and better recognize and respond to change in a resident's condition, again, now and in the future. So with a cancer trajectory, generally speaking, it tends to be more predictable. So people can be at a higher functioning level in terms of, their mobility, ability to participate in their activities of daily living. And that's the blue line there. And then at a certain point, their body becomes overburdened by the disease, and the decline tends to be fairly quick. So over a matter of short months or weeks. And it's a little bit easier to predict prognosis in those settings. With progressive chronic diseases, so organ failures, such as heart failure, kidney disease, COPD, that's the red dotted line on the image. These trajectories tend to be much more up and down. So the dips in the trajectories, let's say that would be like a COPD exacerbation, and someone might go to the hospital and get a course of treatment and recover from that exacerbation, but they're not returning to the same level of functioning as they were before. So ultimately, over time, they are declining and getting weaker and more frail. Sometimes in these cases, death can actually feel sudden or unexpected for families, just because they're so used to people bouncing back from these dips in their health. And so, but understanding this trajectory can help us support families along the way and prepare them. And then the third trajectory on the graph, the green line, is frailty and dementia. And with this trajectory, people can be at a lower functioning level. So let's say bedbound, ceiling lift transfers to wheelchairs, that sort of thing, for quite a long time. So they could be living for months or years in that condition. And so it's a much more gradual course, and especially with dementias like Alzheimer's, it does have a gradual declining course compared with other types of dementia like frontal lobe and Lewy body, which tend to have a relatively faster rate of decline. Again, there's variation within vascular dementia as well, where it's typically more of a stepwise change based on other, vascular accidents, et cetera. And so, keeping this all in mind, residents might have more than one type of dementia. They may have more than one illness trajectory, but having an understanding of these trajectories can help us place where a resident is and assist us with care planning and planning for now and the future. Next slide, please. So in terms of recognizing decline, there are some very important signposts that we can look for as guides to indicate to us that now is a good time to pause and reflect. So things like increasing fatigue, residents spending more time in bed or more time sleeping, or just having more difficulty participating in the same way that they were before. Weight loss, functional decline, recurrent hospitalizations, often for recurrent infections, or persistent symptoms, or a worsening of symptoms. So if we take weight loss on this list, for example, weight loss, we hear a lot about unexpected weight loss and responding to that, but weight loss is actually expected as a resident declines. Often it's always important to assess, is there something reversible here, like some kind of acute illness, but typically there is no reversible cause, and it's related to the progression of disease. And if we just focus on nutritional interventions, like adding protein powder or other supplements to residents' trays as a way to respond to the weight loss, we can miss opportunities to engage residents and families in meaningful conversations on what matters now. For example, are we really meeting their preference in terms of what they would want for a diet texture or their favorite foods? And we can also help prepare residents and families for what lies ahead. So letting them know that, weight loss and decreased intake is expected, and we can normalize this change. And in certain cases, maybe we can help shift the focus from, measuring exactly how much a resident is eating and drinking every day to prioritizing comfort, connection, and the experience of mealtimes together. So the kind of key takeaway of, why it's important to recognize decline is that we want to prompt action. We want to prompt a conversation. So we want to return to conversations about goals of care. We want to give family time to prepare and consider care decisions. We want to update care plans to reflect their current needs, and wishes, and also include plans for the future. And we want to update the whole team so that we can all, be on the same page. This resident has changed. They're not in the same situation now. And here's how we're going to approach their care differently now in terms of that collaboration. And so it's just a great opportunity to stop, zoom out, and make sure that the family and resident, do they realize that they're frail enough, to die at any time now, with a new infection, for example. Can we have those conversations? And again, as some of you mentioned, rapport is a big part of that. And one of our follow-up talks is going to dig more deeply into how we have these conversations. Next slide, please. So there are tools to support your teams in terms of recognizing decline. There's the clinical frailty scale, the chest scores, which are part of the inter-RI assessments. We also have the ongoing assessments over time that are being documented. And really the key here is that we're looking for trends, not single events. And, if we're recognizing a decline, as I mentioned before with the weight loss, we're checking in. Is there something reversible or acute going on? Or is this, again, a reflection of the progression of an underlying illness? And if you're a team member and you're noticing changes and you're unclear where a resident is in their trajectory or how significant this change is, we would certainly encourage you to ask and get on the same page. I know for me in my work in long-term care, I found the healthcare aides were such a valuable source of information on how residents were doing, because they just can pick up on those really subtle changes that may not necessarily be obvious to others. Okay, we can move to the next slide, please. In terms of the key principles of a palliative approach in care planning, goals of care, of course, is very important. And this goes beyond MOST or DNAR orders. So an example that I can think of was, a resident who wanted to eat alone in her room, and her what her goals were. What was important to her was to be independent and autonomous, but there was a choking risk. She wanted to have a regular texture diet. She didn't want to eat in the dining room. So this was a bit tricky because there was some discomfort there of allowing this person to eat at risk, potentially having a choking event alone. But she was able to make her own decisions. We had a fulsome discussion about those risks, and she was very clear with what she was aligned with, was that no, she didn't want a downgraded diet, and she didn't want to eat with other people. She wanted that privacy in her own room. And I think one of the key parts of this care plan for this resident was that we also needed a plan to support the staff. So if we're going to support residents with their goals and wishes, we also need to support staff. And so if the staff did find this resident choking, you know, we had a plan of how they would respond so that they felt comfortable as well with the situation. So another key principle is preparing for clinical events related to decline. And in this case, I can share an example of a resident with chronic pain, CHF, and kidney disease, and she was on dialysis 3 days a week. In the last 6 months, she had had 2 hospitalizations from complications related to fluid overload and pulmonary edema, and she was just generally more fatigued by her dialysis. And her daughter went to the nurse and said, you know, is this a rough patch or is something more serious going on? Which I think is just a great question from the family of just, again, trying to understand what's going on. Where are we, you know, maybe without knowing it, where is my mom in her trajectory? The staff did notice that she had rising scores on the inter-RI chest scores, and her clinical frailty scale did indicate increased health instability. So yeah, this was an opportunity for the resident and her daughter to meet with the team, better understand what was happening currently, and plan for the future. So in this case, the resident wasn't feeling ready to stop dialysis, but wanted to take more of a palliative approach, knowing that things were changing and she was declining. She wanted to focus more on symptom management for her pain and shortness of breath. And she wanted also to have some care planning strategies around fatigue management. So having some more days in bed versus getting up all the time. And yeah, and ultimately the family was able to and resident were able to have that insight that her health was more fragile now. And with a new infection or another health event, she was at risk of decline and death. So I'll share just a couple other quick examples for the key principles. So with addressing living with risk, I think, again, I've mentioned this a little bit already, but there was one story that I really loved where a resident came into long-term care and was quite restless. So he was climbing out of bed, climbing out of his wheelchair. And the team spoke with the family and learned about this resident who had dementia. And the family shared that actually a resident was quite settled at home when he was on the couch. And so the team put a couch at the nursing station, and the resident laid there happily all day. And what I love about that story is, you know, there was an element of risk. A couch is not as safe as a wheelchair or a bed, but it honored what the resident and family wanted in terms of the best way to support that person. And we didn't have to use any restraints or sedating meds. And so we could have these conversations, discuss risks, have it documented, and make that plan. And then lastly, one of the key principles of a palliative approach in care planning is preventing avoidable transfers to acute care. And yeah, the key here is really about, again, having the conversation. So we as care providers can anticipate that with dementia, progressive dementias, for example, that aspiration pneumonias are very common when people are no longer able to coordinate swallowing effectively. And we want to have these discussions with the family ahead of time, because sometimes the default when someone appears unwell is for them to transfer right away to the hospital. And that may be appropriate with their goals. But we want to make sure the family and resident know about alternatives such as giving IM antibiotics at the long-term care home. We want to give them information on what it looks like to take a comfort approach where it's more focused just on symptom management and not prolonging life or doing more aggressive interventions in hospital. And so again, yeah, the key here is having these conversations that are evolving and ongoing and checking in and having them documented ahead of time as opposed to kind of reactive care right in the moment. Next slide, please. So we're going to move on to a case, and I'll just read a summary of the case, and then the following 2 slides, we have just a few reflective questions. So Mr. N has Lewy body dementia. He recently was admitted to long-term care. He is supported closely by his husband, who has been his primary caregiver at home. Since admission, Mr. N has had 2 falls while attempting to transfer independently from his bed to his wheelchair. Mr. N values autonomy and does not like the bed alarm or calling for staff when he wants to get up. He is experiencing shortness of breath on exertion and poor sleep overnight. His husband is distressed and questions whether the move to long-term care was the right choice, saying he's so much weaker now. I don't know if other people have heard that a lot in their career, like, oh, they were doing so well before they came to hospital, or now they're not doing well, or they were doing so well before they came to long-term care. And when I hear people say, families say that, it's just a good indication to me that they probably aren't understanding where the patient or the resident is in their trajectory, that actually they probably were admitted to the hospital or came to long-term care at just the right moment. Because things were changing and they were declining. So we can move on to our next slide. So we'd love to hear from you if you would like to raise your hand and share in a discussion, or you're welcome to put comments in the chat. We'd love to hear from you what you think about what trajectory Mr. N is on and what changes you anticipate for him and what he's at risk for.
Yeah, thanks for asking those key questions, Fran, because this is a great way to apply the principles that you've been walking us through, kind of imagining, well, what do we anticipate for this man? So you could make a comment about what would you anticipate? What trajectory is he on, or what blend of trajectories is he on? And what changes would we anticipate? Because oftentimes the family, they haven't been down this path before. They don't anticipate them. Now, I'm trying to see if I can see things in the chat, but I also want to see, Esther, can you look and make sure if anybody raises their hand that you point that out? So any thoughts on this? Either in the chat or somebody bravely that wants to chime in. So I see we've started to get a little action in the chat. So he's at risk for falls and potentially fractures related to those falls. And then in relation to his trajectory, starting that out, advanced dementia. And another person put a looping trajectory where with his COPD, where we could see change, and then potentially he could come through at a new normal and then decline. So probably a combination of those two, the dementia and COPD trajectory. So it's a declining trajectory, and it may be that that Mr. N doesn't understand that what really is in front of them. Any other comments you want to make about trajectory, Fran, with this man?
Yeah, I think you covered the trajectory. I think we would probably also anticipate worsening symptoms, like with the shortness of breath and wanting to manage that. And then with the dementia progression, other things that he's at risk for, in addition to the falling related to his functional mobility and potentially fractures, but also, the infection piece, and having those conversations with the family.
Yeah, somebody has, Christine has talked about thinking about with his COPD, he may need antibiotics. So getting an infection, watching his oxygenation, because there may be a point in time where he's actually hypoxic. And then I think, she said falls may be anticipated, may not match where his goals are. And I've found that interesting too. Someone may be saying, I'm not worried about falls, but they may not understand the potential implication of a fall in relation to their goal. And I see that Laura has her hand up.
Hi there. I'm a social worker in long-term care. We see this quite often, sort of balancing out the risk and benefit, the high risk of falls for this gentleman, but also the other risk is the level of distress that it is going to cause to him and his loved ones. And with the Lewy body and the dementia piece, an escalation possibly in responsive behaviors if he's feeling like he's being stopped or kind of restrained, being, having to sit in a chair, having beeping going off, that could be really overstimulating and distressing for him. So, and then that leads to all other host of issues around medications and antipsychotics and all that. So, I'm always about harm reduction, trying to mitigate those risks as much as we can. I think the team here is aligned as well with hip protectors and just exploring the whole range of falls prevention measures that we can do.
Yeah, absolutely. We had a situation too where someone understood the risks, choose to get up independently without help, would have multiple falls a week. In terms of managing staff time and that sort of thing, they made a care plan with the family that they wouldn't call every fall. They would just call if it was a serious injury. And again, doing all they could with the space to mitigate the risk. And then also still prepared the resident and family that, there will still come a time where, this person will be so weak that it just won't be possible. But for the time that we can support you in this in-between time to support your independence, we'll do our best to do that. And these care plans tend to be very specific to the person and individualized, but it can be very rewarding to find a way to honor people's wishes.
Yeah, and I really appreciated Laura's comments too about understanding the impacts of this man's dementia, Lewy body dementia, and what may happen if with injury. And so taking people down those roads and the time and conversation that needs to have happen in order to understand those kinds of things that having not gone down before as a family, they may not be seeing.
I think we can move to the next slide. We have a few other questions that we're leading into in terms of the care planning piece. So what should be a part of his care plan now, and what could be part of his care plan for the future?
Yeah, so we started talking a little bit about some of the care planning things, Fran, that you had raised. But so either again thinking about that and some comments in the chat, or you could, if you're feeling talkative, you could raise your hand and anything addition. There were a few comments in relation to care planning that have been mentioned, but anything else that you want to highlight or you would see as important in the care plan? I really appreciated, Fran, when you were talking about the woman who made a decision to be at risk in eating, that you mentioned the important part of the care plan around what to do in the case of whatever you're worried about actually happening. I see Monica has her hand raised.
Hi,
Please.
thank you. I just wanted to, again, bring back the idea of the spouse and appreciating this person's decline in cognition, to ensure that he is on the same understanding that the healthcare team is about what this is going to look like for his spouse, and trying to encourage them to have as much conversation as possible about what his definition of quality of life is, and appreciating what those changes are going to be and what might the spouse, say Mr. M, would want for his quality of life.
Right. Yeah, it really loops back to the conversations, as well as I see in the chat, people are putting in, concrete things like what medications would be used for symptom control in relation to his COPD, what falls plan concretely, the full falls care plan, and what other occupational therapy, what kind of things can we bring forward. And in the chat too is, and I think this relates, Monica, to the conversation that you were having around his autonomy, and what can this man participate in his decisions, and where does his husband need to help in relation to what he knows about what his husband would want from things that they've discussed before. Anything you want to add to that, Fran?
No, these are great responses. I think, yeah, I think it comes back to really learning about this resident and his family and his husband, getting their understanding of the situation, filling in the gaps, and giving them some options in terms of how we approach this, just as opposed to giving a one size fits all, or more, let's just do the kind of saying, you're just not safe to transfer, so we're not going to let you transfer. And so trying to have some room, maybe that ends up being the result, but leaving room to have a fulsome conversation to see if there's any way that pieces of the care plan can help honor autonomy, or what really matters to this family, and again, if there's ways to mitigate risk.
Yeah, thanks so much, Fran. And Deepa is mentioning too, highlighting what gives this man meaning in his life, and emphasizing that involves his spiritual needs as well, kind of remembering the whole person. And Christine, would you like to make a comment?
Yeah, I just wanted to talk about like finding that balance between, what the resident and family want as far as like autonomy, like thinking about transfers and falls, but also the risk to staff.
Mm-hmm.
Like, I know we want to be resident centered, but then how do we then address that effectively so that it's a win-win?
Yeah, absolutely. I think we were Della and I were talking about that before this presentation too, about, yeah, it's really important to make sure what care plans are in place. Include the plan for the staff to make sure it feels supportive for staff as well. And keeping in mind that sometimes we're gonna stretch beyond our comfort zone just with the person on the couch. Maybe that wasn't comfortable for a lot of staff, but we were able to work together around that. So I think staying creative and open, but yeah, absolutely. We never want to put staff in a position where they could get injured, and those sort of risks are always something to consider.
Yeah, and I think when we engage in these conversations early with family, then when there is the time when we say we know there's a window, and we know that at some point it won't be safe for this man or the staff, about rather than dealing with it when it's already not safe, and so I know we're just getting to the top of the hour. So thanks for all those contributions and the contributions in the chat. And I think it reflects, you can see how many different team members' perspectives are needing to come into this to really have a fulsome, and I appreciate the team that we've had here today. So the chats, please read those. Esther, can you just go on to the next? So this is, these are key insights that we're emphasizing. And that, Fran, thank you so much for helping us see the big picture, recognize what matters now, anticipate change, try and avoid as much as we can reactive care, and to have the team on the same page. So thank you and Gita so much for walking us through. And Monica, if you go to the next slide, we're just going to highlight two things before we close. One is that we have a new course in Learning Hub for those of you that are in British Columbia, Palliative Essentials in Long-Term Care. You can search that, and there's these 5 short modules that hopefully provide really helpful links and resources, drawing on things that health authorities and beyond have developed. So check that out. And then if you go to the next slide, we'd welcome you back for the next conversation. And Monica Kelly, who's here, will be co-presenting with Dr. Jennifer Walker. And we're really going to dig more into the other palliative essential, which is conversations and really aligning care with what matters, and explore that a little bit more. So thank you so much for being here and for your contributions in the chat and your contributions to the session, and for the good work that you do. All the best. Thanks to our speakers.